Start.
Good afternoon, everyone. I'm Dr. Prathyusha. I'm a consultant developmental pediatrician at Child Development Center, Lotus Hospitals. Today, my team members, including a special educator and a psychologist, and I, are bringing to you a session on understanding developmental and learning difficulties in the classroom. This session is specifically designed for teachers because school going children spend a significant amount of time in their life in the classrooms with the teachers. And also, as teachers interact with these children on regular basis, any kind of learning or developmental struggles in the classroom are quite apparent to these children, to the teachers, because they have other children of the same age group for their reference. So today we'll be discussing on few common neurodevelopmental conditions which are ADHD, autism spectrum disorder, specific learning disability, and intellectual disability, and how children affected with these conditions present in the classroom. So, can you maximize the presentation? Yeah. So I'll be talking about ADHD and my colleagues will take the other topics. The learning objectives from today's session is to help the teachers understand the classroom presentation of these neurodevelopmental condition and also equip the teachers to learn classroom strategies, how they can support these children in classrooms, and also help them to understand when they have to refer these children for timely evaluation and support. So with that, let's start with ADHD. So ADHD, also known as attention deficit hyperactivity disorder. So most of the times these children are misunderstood as being careless, naughty children, intentionally trying to be defiant or intentionally trying to break the rules or class disturbers. But the truth is that most of these children are intelligent. They're full of energy and creativity. It's a brain based condition. They just need right understanding and support to help them. So, what is ADHD? As I said, it is medically called as neurodevelopmental condition. Simplified, it's a brain-based condition which affects attention, impulse control, and activity regulation. That means a child with ADHD has difficulty in sustaining their attention on tasks which require a lot of effort. They have difficulty in controlling their impulses and also difficulty in regulating their activity levels according to the situation. So it's not an uncommon condition. ADHD affects 5 to 7% of the children globally. That means the occurrence is one child for every 20 children. So if you consider a classroom setting, if there are 40 students, you have at least 1 to 2 children affected with this condition. So it's a complex interplay from these factors. It's because of the interaction between genes, environmental factors, and neurobiological differences. So coming to the genetic factors, ADHD is highly heritable. It runs in the families. So if a child is having an ADHD, there is high chance that one of the parent may also have the same condition or same traits. So it runs in the families. Coming to the environmental factors, exposure to substance abuse during the pregnancy, such as alcohol or smoking during the pregnancy, gestational diabetes during the pregnancy, or at the time of delivery, if there is any premature birth, low birth weight, or oxygen deprivation at the time of delivery, and postnatally, that means after birth, during early childhood, if the child is exposed to toxic elements for let over a long period of time, or if there is any significant trauma or injury to the brain. So these are the environmental risk factors for the condition. Coming to the neurobiological differences, as I said, it's a brain based condition. So research studies show that the brain volumes of children with ADHD are smaller compared to other typical children. So, especially the prefrontal cortex, which you have behind this forehead, it is smaller in volume and its structure and function is different when compared to other typical children. And not only that, the other neurotransmitters or simplified chemicals like dopamine and norepinephrine, these chemicals are very important for a child to have attention, for the reward, for the motivation. These chemical imbalance is also present in a child with ADHD. So, what are the core symptoms of ADHD? Inattention, impulsivity, and hyperactivity, as we discussed in the previous slide. So, there are three types of ADHD. A child can be pure inattentive type, pure hyperactive and impulsive type, or a child can have combined features of inattention, hyperactivity. So let's understand how these core symptoms present one by one. So coming to the inattention, how a child with inattentive type of ADHD presents in a classroom. So this child fails to give attention to details. They have difficulty in sustaining attention on tasks which require a lot of mental effort. They get distracted very easily. They are forgetful in daily activities. They cannot keep track of time. They tend to make simple, careless mistakes which are actually disproportionate to the intelligence of the child. They have difficulty in following and processing the instructions given by the teacher. And they tend to lose items frequently, such as the stationary items. They tend to miss their pens, pencils, or sharpeners, which they carry from home. And they appear as though they are not listening. Say, for example, the teacher passes an instruction in the classroom. Children, open your notebooks, write the heading, write today's date, and copy question 1, 2, 3 from Max textbook. So, our child with ADHD, by the time they open the notebook, they tend to forget or they cannot process the other instructions what the teacher has passed. They might have lost in their own thoughts, or they might have got distracted by the noises happening in and around the classroom, or they would get distracted by the chit chat happening behind them, or they might even get lost in their thoughts. So it's not an intentional behavior. They tend to have difficulty in processing a complex instruction passed by the teacher. So this is how inattentive type of ADHD presents in classroom. So next we have hyperactivity. So this children who have hyperactive type of ADHD, they tend to constantly move. They act as if they are driven by a motor. They are constantly on the go. They fidget a lot. That means they keep squirming on seat. They tap on the feet, or they keep playing with their things that they carry. They leave their seats frequently, even when they're expected to sit for a long time. They talk a lot and they have difficulty in performing leisure activities quietly. So in a classroom, when, for example, the classroom is like around having a 40-minute session, when the other children are able to attend to that session, when they are sitting at one place and attending to teachers' instructions and finishing their activity. So this child who has hyperactive type of ADHD, they tend to, they cannot sit for a long time. They ask for frequent breaks, either in the name of using washroom, either to drink water, or just to have a short walk. They keep fidgeting a lot. They cannot sit still for a long time. This is how hyperactive ADHD presents in a classroom. Next, we have impulsive type. Children affected with this condition have difficulty in regulating their impulses. They tend to interrupt and intrude on others. They act without thinking. They blurt out answers even before the question is completed by the teacher. They have utmost difficulty for waiting for their turn, either in terms of conversation or in terms of any action. So, we have discussed the core symptoms of ADHD: inattention, hyperactivity, and impulsivity. But for a child to have ADHD, in order to suspect ADHD, the child should meet the following diagnostic criteria. That means the symptoms that we just discussed should be lasting for at least 6 months of period. The symptoms should be inappropriate according to the child's developmental level. The symptoms should appear at least in two or more settings, for example, home, school, playground, or any other public place. The symptoms should be present before the age of 12, and very importantly, the symptoms should cause significant impairment in daily activities, social functioning, peer relationships, and academic functioning. Only then a child will be suspected with ADHD. So many teachers and parents have a question: are all hyperactive children ADHD? What is the difference actually between a hyperactive or a highly energetic child or a naughty child versus ADHD? So let's understand the differences. A hyperactive child is usually context driven. That means they have these kind of features of hyperactivity, impulsivity in one situation, but not across all the settings. For example, if you consider a child who is highly pampered, they might present with these features in the at home, in front of the teachers, in front of parents, but they may not present with these symptoms in classroom in front of teachers. Whereas a child with ADHD will have these kind of symptoms across multiple settings. Their behavior is same everywhere. A hyperactive child can control their impulse if they want to, whereas it becomes very difficult for a child with ADHD. Then the energy levels in hyperactive child come in bursts. If they have very interesting activity, or when they're very excited for an activity, their energy levels are at peak. But once they tire down, once their battery get drained, they tend to slow down. Whereas a child with ADHD tend to have persistent energy levels throughout the day. Sometimes it gets very difficult to put these children at night because they have energy carrying all the time. Then coming to the hyperactive child, they usually their behavior sometimes is can be age appropriate. For example, if you consider a preschool child below 6 years of age, some amount of hyperactivity, inattention, impulsivity is acceptable. But when you have this kind of features When you suspect these conditions in a child, which is not appropriate for the child's age, then you have to suspect ADHD. Then hyperactive child, as I said in the previous slide, usually they don't have any kind of impact on occupation or social functioning or academics. Whereas ADHD child, they have their ADLs, that means activities of daily living, or their social functioning, their peer relationship, academics are usually affected. So that makes a difference between a hyperactive child and ADHD child. So let us burst quickly some myths about ADHD. Is ADHD caused by bad parenting? Definitely not. It's a brain based condition. It's because of neurobiological differences and it is a genetic condition. Can people with ADHD focus on few things like screens or other activities? Yes, they can focus. Their attention is usually scattered. That means when the tasks are boring or when they are routine, usually the child tend to lose focus. But if the tasks are new or they create a lot of interest to the child, for example, say video games or constructing a Lego building, or it can be watching screens, they can hyper focus for prolonged period of time. Then kids outgrow ADHD. It's a myth. ADHD often continues into adulthood. 60 to 70% of the symptoms continue through the adolescence into adulthood. ADHD only affects boys. It's a myth, definitely. ADHD affects both girls and boys. The ratio is 2 is to 1 in boys compared to girls. But the difference is that in boys, they're usually present with hyperactive or impulsive nature, whereas girls usually present with inattentive nature. They tend to be, they look like daydreamers. So there is high chance of underdiagnosing girls who have ADHD, but it affects both the genders. Then is ADHD equal to laziness? No, it's not. It's a condition which affects motivation and executive functions of a child. So, what is the ADHD care pathway? So, once a teacher suspects a child is having ADHD according to the features that we just discussed, the next step is to discuss with the parents sensitively and together discuss what are the struggles and concerns the child is facing and take a collaborative effort to refer this child for further professional evaluation. It can be a developmental pediatrician or psychologist or any multidisciplinary child development team. So, with the features that we discussed, we cannot diagnose a child as ADHD. There are other conditions which can mimic ADHD, like if you say autism spectrum disorder, a child with global developmental delay, intellectual disability, a child who is deprived of sleep for a long time, sleep disorders, and also a child who has hearing and vision impairment. So, these conditions can mimic ADHD. Children affected with these conditions can also present with hyperactive, impulsive, or inattentive features. So there is a thin border between these conditions. So you definitely need a professional evaluation to understand that this condition is ADHD. So once a child is referred to a professional, we do comprehensive assessment for diagnosing the condition. And once a child is said to have ADHD, diagnosed to have ADHD, we plan intervention, which includes psychosocial intervention. That means parental training program, environmental modification, behavioral therapy, plus or minus medication, depending upon the severity of the condition. And there actually the journey begins. Once the child is planned on intervention, this child has to be followed up by a professional regularly to monitor for the progress, to see how the symptoms are resolving. Are there any evolving symptoms or are there any evolving comorbid conditions along with the ADHD? So the collaboration between the parents, teachers, and the professionals is utmost important in the child care of this condition. So, how teachers can help a child who presents with ADHD in a classroom. So, let us learn few simple classroom strategies. These are simple, but they help a lot to help the child to stay focused. So, these are the attention supporting strategies: timers, checklist, seating strategies, and chunking out the tasks. So, coming to the timers, one common difficulty in children with this condition is lack of time awareness. They cannot keep track of time. They don't have this awareness of time. That is the reason many parents come when they come to us. They discuss that child is taking a lot of time to get ready for the school, or when we give them a prompt that you have only 10 minutes left to finish your bath, the child is not understanding. It's because they do not have concept of time awareness. That is why we externalize the time. We use visual timers. These are like alarms. Instead of saying you have to finish this activity in this particular time, you set the timer or the alarm so that the child will understand that the child has to finish the activity in this particular amount of time and how much time is left for this activity. That's how visual timers can be useful at home and at classroom as well. And coming to the checklist, sometimes multi-step instructions or complex instructions can be very overwhelming and tiresome for children with ADHD. So this visual checklist helps a child to chunk out the steps. For example, in the during the exams, when the child has to finish writing the questions and submit, sometimes they tend to they make careless mistakes because of inattention or tend to rush. So in order to reduce that, we use this checklist. So here you can see the child has to read the question, they have to plan their answer, do their work, and finally check their work before submitting. This helps these children to accomplish their tasks independently. Next, coming to the seating strategy, as I said, these children are easily distractible. In order to reduce the distraction, these children should be seated in front of the teacher, apparently in the front row, away from windows and doors, which can cause distraction. Next, complex tasks can be broken down into simple, achievable steps. Coming to the visual cues, most of these children are visual learners. Any matter or presentation which is given visually to this child helps reduce the anxiety and improves predictability. So for visual supports, we have schedules, desk reminder cards, task charts, and color coded materials. So coming to the visual schedule, as you can see, the schedule of the class can be displayed in the form of visual schedule in front of the child. So the child is stays track of what is the schedule like of the classroom. He or she will understand what is the planning of the periods and also reduces the resistance between the periods and the transition between the activities. Next, coming to the desk reminder cards, sometimes the teachers give multiple instructions or multiple prompts for a child that they have to they have to be adherent to the classroom rules. So instead of giving multiple verbal instructions, these kind of desk reminder cards help the child to self monitor their work. So you have different kind of desk reminder cards that reminding the child has to raise the hand before they can ask a question or before they can answer a question, reminding a child should sit properly during the class, reminding them to check their work once again before they submit. And these are the different types of desk reminder cards you can display in front of the child. Next, coming to the task charts. So any kind of task or activity can be chunked out into small achievable steps. For example, say if the child is solving a max problem, so we can divide these into small steps. First, read the problem, then underline the key numbers, choose the operation asked in the question, then solve your problem. Finally, check your answer before you submit. This is how visual task chart helps the child do this steps independently. Coming to the color coded materials, again, there is a difficulty in organization in ADHD. So these kind of color coded materials, which are specific to each subject, helps the child to stay organized and also reduce the confusion. So, how do we manage hyperactivity and impulsivity in these children? So, these children tend to move a lot. So, movement, why do they do so? With movement, there is increased blood supply to the brain, specifically to the prefrontal cortex, which is responsible for a child to have attention and focus. And not only that, with movement, there is increase in the secretion of these chemicals, dopamine, norepinephrine, which are helpful for a child to stay focused. And again, movement helps the child to burn out the excess energy. So these are the different ways a movement helps a child. So they're not doing it on purpose. Movement helps the child to regulate themselves, to come back to their original state of attention. So how can teachers help? So you can make these movements purposeful and planned. For example, classroom errands like distributing books or dusting the board or getting water. These movement jobs can be given to the child, or the child can be asked to stand intermittently. Standing desk option can be provided. Sensory breaks. Sensory breaks are planned scheduled breaks during which a child is allowed to squeeze a stress ball or play with a stress ball, fidget with the sensory tools. A child is allowed to go for a short walk, drink water. So this is how planned scheduled sensory breaks help a child, and they can also have stretch breaks. So when should a teacher give these movement breaks? In between long lessons, when you understand that the child is starting to be restless, and when you're about to give a attention heavy task, and also in between when the child is sitting for a long time. These are the different conditions where you can give these scheduled movement breaks. So these are the different sensory tools that they can carry to the classroom. They can either use stress balls, other kind of sensory tools. They can use alternating seating options like wiggle cushions or movement cushions. They can use these resistant bands on desks or chairs. They can use their noise reduction headphones when the class is not going on for a break period in order to reduce that overwhelming by the excessive sound from outside. They can use these weighted lap pads, or they can also use a calming corner where they can go have some calm time and they can come back. So these are not like any kind of punishment, or we are not giving a special treatment to these children. Actually, these are proper movement breaks which helps a child to regulate their senses, and it helps them to stay focused for a long time. So these movement breaks are absolutely necessary. It's a job of the teachers to reduce the stigma among other peers, to improve the peer acceptance for using these sensory tools in classroom. The teachers and the parents commonly can combinedly work on this report card or goal card. So this goal card, as you can see, contains goals. The goals can be chosen by the teacher. It can be related to the academic work, or it can be related to the classroom rules, or even peer relationship. So the teacher selects the goals, and they can rate the goal as per the child's behavior. And the child will achieve a star for every positive behavior. And the end of the day, that card will be given to a parent. So if he or she collects enough number of stars, or he gets a good rating, the child will get a reward. The reward here is not just tangible thing. It's not just a materialistic thing all the time. It can be a simple appreciation, a positive reinforcement. It can be extra playtime. It can the favorite food can be cooked. So these all things can be used as rewards. Immediate reward and positive reinforcement is very helpful for these children. If you say that if you study well now, at the end of the year you're going to score well, that does not work in a child with ADHD, because they don't have this delayed gratification. They cannot wait for a long time to have their sense of accomplishment. Everything has to be immediate. Next, so when a child is not supported for a long time, or a child with ADHD struggling with this condition, when is not supported for a long time, you can see how it affects a child overall. So why early identification intervention matters? Effects of untreated ADHD. It affects the child's self-esteem. It brings down their confidence and also affects their psychological state. They can have comorbid conditions like anxiety, depression, conduct disorder, oppositional defiant disorder, or they can have suicidal thoughts and behavior. It also affects the family relationship, their relationship and the spouse when they grow old. It can affect the society, and most importantly, they can have a bearing on the legal consequences. So children with impulse, not children, when they grow into adolescents and adults, when they tend to have this persistent features, they can have this bearing on the legal consequences also. There is high risk of delinquency. They can involve in road traffic accidents, violation of social rules, and increased risk-taking behavior, substance abuse, and sexual abuse. These are the effects of untreated ADHD. So teachers play a very important role in supporting a child with ADHD. They actually act as a bridge between the parents, clinicians, and the child. So the teacher's role is extremely important. It's not about diagnosing a child, or it's not about attaching a label to a child, but understanding their struggles, supporting them, improving the and promoting the peer acceptance, and most importantly, timely referral for further evaluation and support. So, with that, a teacher can change the whole trajectory of a child with ADHD. So, with that, I conclude my topic of ADHD. The next speaker for today's webinar is Maliha. She is a special educator at CDC Lotus Hospitals, and she will be talking about specific learning disability. I hand over to her. Thank you.
Hi, I'm Maliha Athar, special educator at CDC Lotus Hospital. Today I'll be talking about specific learning disability. I'll present my slide. So, specific learning disability. It's about children who are having specific kind of disability into psychological or search or training up. It can be like understand SLD. We'll be talking about spot red flags and support growth. So let's understand what is SLD. It's a hidden challenge. Specific learning disability is a neurodevelopmental disorder affecting how the brain processes and stores the information. Like specific, neurobiological, and persistent. Affects the reading, writing, or math, while other skills remains the same. Neurobiological, it is not a result of poor parenting or lack of efforts. Persistence, these difficulty continues, it doesn't go by changing the classroom setup or something else. The big three types in SLD are dyslexia, dysgraphia, and dyscalculia. Dyslexia is like children having difficulty in talking or phonological awareness, and dysgraphia is like writing impairment who struggles to write properly and gets confused between B and D, something like that. And dyscalculia, it's about maths. They struggle to understand the symbols and how the math is implemented. General signs to watch to see if the child is having SLD. Compare like memory issues, processing gap is there, and directional confusion, visibility of awareness, that and battery alert, speed. All these things matters. Teachers, how can you flag children with SLD? Patterns to record, how you can record a child is dealing with SLD, reads saw as was or skip small words, oral answers are much better than writing, struggles with place, values or symbols, poor comprehension. Now let's see the difference between SLD and slow learner. SLD children IQ is above average and slow learners have below average. And when it comes to academic profile, SLD has a spike like strong in some areas, but slow learners they lack in most of all the areas. And learning rates struggles in specific areas in SLD, but when it comes to a slow learner, learns everything on a slow pace. Instructions need specific instruction strategies. Like SLD, we need to be very specified. When it comes to a slow learner, need specific and simple pace. It should be in a low pace so the slow learner can grasp. Now let's identify early identification path. So how can you identify early to the child who has SLD? We can observe and document and parent meet and then refer to a specialist. So when you're observing, see the pattern of the child and your overall performance and potential. And when you're documenting, just keep the raw material of how the child has been working with, like the written part of the child, making the changes which are not abnormal, and then discuss it with the parent and ask them to go for a clinical diagnosis. Now, how can you implement inclusive classroom for children with SLD? So these are the simple things you can help them. Chunking, like if it is a big amount of information, just cut it down to a small pieces and it will help them to get it faster. Or visual aid, you can give them a graphic organizer kind of thing, or support memory with color coded notes. And accommodation, give them a extra time to get it. Now you can also use multisensory teaching, like hearing, kinesthetic, and visual and creative. How can you use this? Auditory, you can use like audio, speech kind of thing to memorize easily, and visual, you can give them more videos and all. Now we will talk about a case study. This is a child who is 8 years old and high creative verbal articulation. He excels in science discussions, but struggles to read a grade 2 paragraph. Avoid writing and expressive high fatigue. Now the results. How can you change this by implementing an inclusive classroom? We can be allowing that child to give reports in a videographic format and not in a written or oral format, so that easier for them to present their information and knowledge what they have. Thank you. Now I'll be the next topic is uh, ASD and intellectual disability by Laxmi Priya, a rehabilitation psychologist.
Hi, good evening everyone. I'm Lakshmi Priya, a rehabilitation psychologist at CDC Lotus Hospitals. One second. It's not coming. Slides.
Wait, it will not come.
Okay. So now today topic I'll be presenting about autism spectrum and is it visible?
No, she discontinued me. Don't look at me.
Okay, so today I'm going to discuss about autism spectrum disorder and intellectual disability. So, by understanding like what is autism, have you ever heard a student who who communicates differently and has strong interest or to the routines or to the changes to the everyday life activities and prefers quiet spaces or need time to warm up to others? So the student might be these factors can consider this features of the autism. So autism is a neurodevelopmental disorder. So where there is a differences in the children, where their brain process differently and unique way of understanding. And autism is a spectrum. Everyone have a different way of presenting the symptoms. So, autistic student might have differences in communication and sensory processing and socialization factors. So, some children may speak only few words or use one or two words to communicate, and that might be speaking with the device, use of device or pictures or gestures to communicate. And they have sensory processing. They are overwhelmed with the lights or textures with the lights, so they may close their ears and all. That might be because they need to regulate themselves in order to feel calm and all. So they might seek out certain sensations like movement or pressure. So they have even also have difficulty in socialization, like they may prefer playing alone or maybe prefer one time with one person at a time, because they express feelings difficulty and they have understanding differences uniquely. That doesn't mean they don't want to socialize, and they may play in a different way that is not expected, what is social expected way, but they might want to mingle with others. So that doesn't mean they don't want to mingle. We need to understand the difficulties they are going through. So where does autism come from? So clearly, even we don't know exactly from how it is coming out. However, the research suggesting that there might be because of genetic links, neurological differences which present at birth, or it is important part of a person's identity. So causes of autism, it's not because of the vaccines or parenting styles or any actions taken by the families or caregivers. So many autistic children by when they are in the crowded places or in the classrooms or in the new environment. Why does he do that? Why he or she does do that? Maybe because they have sensory differences, because noises can feel too loud, or even it's painful for them to adjust to the environment, and because there is certain part of the brain which handles the sight, sound, touch, taste is extra sensitive. So some students might cover their ears, wear headphones, and need quiet time for them to, in order to adjust to the environment or wherever the situation they are in. So we need to understand: is it because of we need to prepare them in advance with the by covering their ears and using visual schedules. So some students or some children with autism repeats whatever they are instead of answering, they repeats the question, why does it happens? So maybe because of echolalia. It doesn't mean they are repeating, it's their way of learning things. Sometimes repeating words and phrases helps their processing very easy, so that they can learn new language or communicate. They be better able to communicate. So when she doesn't have any other way or to respond yet, so, echolalia is a form of communication but should not be taken literally. So, acknowledge whatever they are repeating, accept it is a part of their learning and communication. That's how they learn and process the information. So some students use place herself during the situation, whenever there is a social situation or even a school, or instead of joining a group or playing with other children with the same age. Why does it happen? Why they prefers to play alone? Like, because group play can be confusing and noisy for them, or maybe feel overwhelming for them, because too many rules, too many emotions they need to understand. Even because they have social communication difficulties, their brain process very in a different unique way. That doesn't mean they don't understand, but they process slowly, especially if social rules aren't clear. So it will be noisy and confusing for them. So it doesn't mean they don't want friends. They might connect in a different way. We need to understand why it's happening, and need extra time and support to feel safe joining in. So how you can address these concerns? So by being supportive, maybe while allowing them to be following their lead, like how they are first allow the free play, like how they are accessing to the tools or how they are adjusting to the environment, and accept their way of thinking and playing and talking. So give the children with autism some time to respond, because it's new environment. It's not like others, like how they adjust quickly to the environment, but they may take time to adjust to the environment and all. So respect their boundaries and space. Let them communicate in a way that works for them. And yeah, as I said before, follow their lead. So, presume competence. When we presume competence, we create space for growth instead of setting limits. So, speak directly to the children instead of setting aside or parent next to them. Don't assume the student isn't capable of learning or understanding, but they understand the process difficult. They process slowly. With the consistency and effort, they can learn. They do good in the world. They learn. They can be good learners too. So support their social interaction. Sitting near the classmate, building next to someone with blocks is also a kind of social interaction. That doesn't mean like how expected we, how we expect, how we respond. We They might vary from children to children and children with autism, but show peers how to invite autistic children into a group without pressurizing them or bullying them. Instead of making faces at them, you can present how to invite them by making sitting next to them, following their lead, maybe whatever they are comfortable with the play toys, or you can use them, and you can ask the playmates to play with them in order to join in the group and to develop the social interaction. So build trust by respecting a student's refusal when they say no to the game or activity. So respect that. Maybe they're feeling overwhelmed, they are confused, they are very difficult to process. So just don't respect their decision when they say no. So now I'll be talking intellectual disability. Autism is also will come along with the comorbid condition, which is intellectual disability. Intellectual disability is a neurodevelopmental disorder. It involves significant milestones, significant limitations in intellectual functioning and adaptive behavior, which include self-help, dressing themselves, communication, occupation, like self-help, eating difficulties. And also some people with intellectual disabilities can do and learn new skills, but they learn more slowly compared to the age groups, whatever with the presenting with the current age group. So, what might be the causes of intellectual disability? It is also called as ID. So, maybe because of genetic conditions which include Down syndrome or Fragile X syndrome, maybe prenatal factors where there will be a stress during the pregnancy time, maybe because of mother's exposure to some harmful chemicals or radiation, or maybe alcohol consumption, or maybe having gestational thyroid or BP, or diabetics per se. So even it also, one of the cause is also a birth complication when there is a less oxygen condition during the birth time, or when there is a cord around the neck, that will cause respiratory distress, or maybe because of the force of delivery sometimes. Yeah, these might be the cause of ID. And the postnatal causes, which include damage to the brain uh, by falling, and which caused significant damage to the brain. So, what are the symptoms of ID? So they actually failure. They have failure to meet developmental milestones, which includes speech from beginning, maybe neck roll, sitting, crawling, and sitting and walking, running, and speech. These are the milestones can be delayed from the expected age range, and problem in learning to talk or difficulty in speaking clearly. So they have memory problems in reasoning and problem solving activities, like when we asked like when we give simple instructions, where they have difficulty to remember even to follow the simple lead. So inability to understand the consequences of their actions when they perform some action, like they don't even understand what is the cause of it, and they don't even understand what is the consequence of this. So behavior is inconsistent with the child at age. When you compare with the same age group, so their behavior might not be the okay, like in order in the way of understanding the environment, way of social skills wise, or talking appropriately, understanding the situation. They might be inconsistent with the child age, all these factors. So they lack curiosity sometimes, and where when you put something, and normally children will be excited and show jumping, and will be curious to open whatever you bought. But children with ID, they lack that such curiosities. And learning difficulty, they will be slow learners. They will be having difficulties to understand the basic alphabets, or maybe math difficulty, communications, and these are all the difficulties they will face. So they have difficulty to lead an independent life. Even for example, maybe writing, they have difficulty. For bathing, they need some assistance. They, in order to eat themselves by independently, they have difficulty in such areas. And even whenever going to the shop and purchasing something, they have difficulty in money transactions. So all these difficulties will show up. They have such kind of difficulties and all. So in intellectual disabilities, we have levels. One is mild intellectual disability, moderate, severe, and profound. So in mild intellectual disabilities, they can learn academic and vocational skills, like with support. They may lead independent life with guidance. But in moderate intellectual disability, required support for communication and their daily living skills. Benefit from supervised work or structured way of learning. They can lead their life independently when there is a structured and supervised supervision will be there. They can lead. So severe intellectual disability, where they need continuous support for the self-help skills when daily functioning. So limited communication abilities will be there. In even drooling will be also there in children with severe intellectual disabilities. And profound intellectual disabilities requires support in all areas of the living, like self-help, eating, dressing. The drooling will be more, and even they don't support for the following simple instructions. They will so there will be significant developmental and all the milestones, like sitting, crawling, walking, and running. All speech, all the adaptive skills and developmental skills will be delayed in profound intellectual disability. So how these behaviors will manifest in children with ID? So mostly because they don't have they have differences in understanding the because of delay cognition development, they have difficulty with reasoning and problem solving. So when they are playing some game, mostly they'll not understand how to play and how to lead that game and lead a life. So their behaviors will be inconsistent with the other children. So they don't know how to express it properly. So in that way, they'll show up with aggression and like hitting, maybe shouting, or in that way it will manifest. And they will be dependent in the basic skills, like with academics, or with the dressing, or with the basic eating things, or with play skills, or whatever, following the rules. In all these areas they will be dependent. So they will be, because of having difficulty with the cognition, they might be withdrawal from the social activities. And they have lack of impulse control and passivity. They don't think why what is is happening, what is the consequences if I do this act, if I throw this toy on the floor, my mother will come and she'll shout on me. They'll not think, or they don't even understand how to express or how to behave appropriately in the situation. They have tendency, because they're having so many sensory kind of issues or something, they have tendency towards self-injurious behavior. They might hit himself and cause so in that way they will be self-injurious. They have low frustration and tolerance difficulties, and difficulty in paying attention. Whatever we are telling to them, they have difficulty to understand, and difficulty to do it, and difficulty to manage whatever they are doing it, and whatever instruction, following commands, even if it is two step or three step, whatever the age group they are performing, they may have difficulty in paying attention and implementing the things. So some people may with ID may also have specific physical characteristics, which we can notice with which include having a short stature or facial abnormalities. They have small or nose. You can see all these facial abnormalities for the condition. So how the treatment works here? So early intervention programs can help them to overcome all these difficulties. It doesn't mean disability does vanish and all, but they can lead their life with independence, and by having a quality of life, because in early developmental age the brain is more rigorous, and the brain develop rapidly. It's very easy to develop a language, social skills, or behavior and understanding skills. So special education and individualized learning plans, if children is in school, in a school, for example, a person is having intellectual disability, they can in school they can accommodate a special educator, and include individualized learning plans and customized. They can change the curriculum according to the needs of the child by considering the level of the ID where they are in. Behavior therapy, of course, it will be very helpful, because it also, which includes reinforcements, and with the most of the behavior techniques, which includes shaping, chaining methods. They can learn new things, and in that way they can we can in behavior therapy they can help themselves in that way. So occupational therapy, when there is a difficulty in holding pencil, that is a fine motor, or gross motor difficulty in walking, so occupational therapy will be helpful, or paying attention skills, when children are having a difficulty with attention skills. So occupation therapy will be very helpful, or proprioception difficulties. Some children, they don't have body awareness, so in occupational therapy will be useful in that way. Sometimes the speech delay will be there, articulation issues, and pragmatics, understanding the pragmatics of the situation. It will be very difficult for the children. So in that way, speech therapy will be useful for children who is having intellectual disability. It also include parental training, family counseling, parental management techniques, like how to make them learn something effectively at home, how parents can lead, how can they can support the children who is having ID. We can do it in a parental training. So in pharmacotherapy will be used in some cases where because of social withdrawal and all, they might have some other extras, like situate extra condition, comorbid condition. So in that cases, pharmacotherapy will be using. So how ID can you pass on the instruction, go sit on the third page. You can tell, you can show where is the third page, how many steps he need to take, or how to interact with the other children. You can show, like, say hi, hi, how are you. You can break the task, or you can make them learn in such ways, or whenever there is some in such way that you can make him to understand, make them to understand. So provide visual aids. Yeah, visual aids are like very useful, like they can understand with the pictures and all, photographic memory and all. Yeah, it's very helpful. And repeat it, you have to repeat something again and again so that they can understand better with the repetition and fall with having visual aids. So encourage participation through positive reinforcement. Whenever they are learning something new, don't consider it. They learned something new from yesterday. So encourage it with the positive reinforcement. So maintain structure and supportive environment where other children can support them through the learning, or through while playing games or socialization, etc. So, what is the main differences between ID and ASD? ASD with the comorbid condition of ID. So, in ID, the main difficulty is having problem and reasoning difficulties because of delay in cognitive development and low intellectual functioning. In ASD, especially, they have difficulty with difficulty with social communication deficits and behavior also. So yeah, when children is presenting both ASD plus ID, they have both delay in cognition, intellectual functioning, adaptive skills, and social deficits also they may have. So, in when coming to the social interaction, so children with ID, they have interest, but they don't understand how to proceed in a social environment and an expected social play. They have delays in understanding, but they may show interest in playing thing and socializing with others. And in children, when coming to the children with ASD, they have difficulties in understanding social cues or interaction. But when coming to the children with ASD and ID, they have severe deficits in social and interaction difficulties. Communication, when coming to the communication, they have delays in cognitive. Speech and language delays will be there due to cognitive delays. And in coming to the ASD, in the communication of children with ASD may be unusual or atypical. So in coming to the ASD plus ID, they have significant communication impairment. So repetitive behaviors like doing the same thing again and again might be absent, usually absent in children with the intellectual disability. But in ASD at present, they keep on playing the same thing again and again. They do the behaviors again and again, maybe like fidgeting or anything. They, because of regulation and comfort, because of they need to regulate themselves. But in ASD ID also at present, the repetitive behaviors. The IQ level of ID will be below average, which means like less than 70, can less than 69 is considered as a ID. If you come into the borderline, if it is 84 and below is come as a ID. So sometimes children with ASD, they have normal IQ, but they have socialization difficulties. It varies from children to children. Sometimes few children will have high functioning autism. Sometimes they have difficulty in cognition also. So in ASD, when it comes to ASD and ID presenting, they have below average performance, below average IQ levels, less than 84 and less than 84. Yeah. So when coming to the adaptive skills, in ID, usually there will be delays in daily living, like skills like dressing, eating, toileting, and all occupation and etc. But when come to ASD, they have difficulty mainly to the social adaptive difficulties, and they have difficulty in flexibility also, transitions also they have difficulty in that. But when comes to ASD plus ID, severe and difficulties in independent functioning. So I want to close this topic today by addressing, like, please remember that behavior is a form of communication. So instead of thinking that how should I stop this behavior and all, try to develop why this behavior is, what this behavior is trying to tell me, and all. In this way, we can understand and creates inclusion, because inclusion helps every children to thrive. So yeah, thank you.
Yeah, thank you both of you. So that's the end of today's webinar. We have actually discussed on four important and common neurodevelopmental conditions, which are autism spectrum disorder, attention deficit hyperactivity disorder, specific learning disability, and intellectual disability. These are the most common neurodevelopmental, also called as brain-based conditions, which present in children. And you have also seen how children affected with these conditions present in the classroom, and you also learned how to support these children in the classroom. So the role of teachers is for identifying these children early and also supporting them. Prompt referral to a professional can actually help these children and manage better. If we have any questions, we can quickly address. My child avoids eye contact and prefers to play. Is the question incomplete? If it prefers to play alone, should we be worried about autism? Yeah, so when a child is avoiding eye contact, when the child has deficits in socialization as well as deficits in communication skills, if the child is preferring to be alone, so preferring alone is called as solitary play, which is actually accepted below 1.5 years of age. But even beyond that, if a child is preferring to play alone all by themselves, a child is avoiding eye contact all the time, or child has difficulty with socialization communication, then we need to suspect this child with autism, and this child needs further evaluation.
So my child speaks well at home but not in school. Is this related to ASD or shyness? So sometimes it might be anxiety or shyness, or maybe selective autism. Children may have social communication difficulties with ASD. So we need to address all the domains, and before considering what it is, to come into the diagnosis. So how he's adjusting, we need to address all the domains in the school and even outside. Yeah. So parents are often blamed for poor parenting. Can autism occur because of poor parenting style? No. Autism doesn't occur because of poor parenting styles or showing lack of affection or family environment. Autism is mainly caused by genetic or autism is mainly genetic and neurological condition. So it's not because of parenting style. Or can speech delay always indicate autism? Uh, Sometimes speech delay, through proper evaluation, we can deal. So, because maybe there may be a temporary delay, or whether speech is delay after, even after 3 years of age, if it is, we need to consider. So, so yeah, need to consider that. So yeah, in autism and intellectual disability, social communication and social interaction difficulties will be there. In intellectual disability, it is because of cognitive delay. But in autism, it is because of social communication and behavior concerns. So we need to address properly through accurate assessment and evaluations. So it not exclusively to the we can't relate after accurate diagnosis, after accurate evaluation we can say that it's not exactly related to the autism. So yeah, managing daily living skills like dressing, eating, toileting independently is always the early sign of intellectual disability. It may be not prominent in the early infancy or infancy or toddler ages. It may We can see clearly the manifestation during early school years. So yeah, it's a sign of early sign of intellectual disability.
So, how
So
important is you want to cover?
no, no, you can.
How important is early intervention in improving a child's development and independence? So, early intervention is of utmost importance for every condition that we have discussed below in this session because it matters a lot. A child's brain is almost 80% completed by 2 years of age. It's almost 90% completed by 3 years of age. So, this first few years of age is like a golden window. It's a golden period because of neuroplasticity. That means whatever wiring that has gone wrong during the developmental stage because of these conditions, there is a capacity for the brain to change and adapt based on the intervention that we provide to a child. That is the reason we always insist on early intervention, early support, because it does make a lot of difference in the development and learning of a child. Also helps the child to be independent. So start the intervention as early as possible. Do not wait for to hear from do not let the child symptoms to be very obvious for every people to note. So when there are red flags noticed by a professional, or when you yourself, when compared to the other child in your family, when you understand that the child is growing or developing or learning differently, seek the professional help as early as possible.
So
So my child is slower than other children in understanding and learning daily activities. How do we know if it is an intellectual disability or just delayed development? So there is a border between intellectual disability and developmental delay, which we call as global development delay or isolated development delay, depending upon the where the delay is, which domain is actually delayed. For a child below 5 years of age, if the child is delayed in any kind of domain, we term this child to have global developmental delay or isolated delay, depending upon which domain is affected. But beyond 5 years of age, only beyond 5 years of age, we can use the term intellectual disability because it is related to IQ or cognitive functions. So a child who is delayed in development below 5 years of age usually has high chances to have intellectual disability beyond 5 years of age. So that is the difference. It's a continuum. Are there any other questions? I think that's all the questions are. So thank you very much for your participation. Also thank you Lakshmi, Priya, and also Maliha for your participation in today's webinar. So we are a part of child development team in Lotus Hospitals, Kukatpalli. In case you face any kind of difficulties, either with respect to learning or with respect to development in your child, it can be a parent or it can be a class teacher. So we will be available at Kukatpalli branch, CDC, Lotus Hospitals. Thank you so much.